We're going to focus on hip fractures now, and I know you might say that this is something that's quite common and you know it very well, and I'm sure that there's a certain element of this that you're very confident on. I've touched base on previous videos where I've said that predictable questions give you predictable answers. So if something is very common and you end up seeing it daily, that is fair game, and the knowledge you're expected to have on it is very high. If it's something that's very obscure, like let's say pediatric malignancy and primary bone tumours, that is something that is not very commonly discussed and not commonly encountered. So therefore, your knowledge on that type of stuff doesn't need to be as deep. So what you'll find is that stuff is very easy to fail in the trauma station, and it's probably the most commonly failed station in the vivas and also in the long case elements as well, that if you don't have a firm enough grasp of your orthopedic trauma stuff, it's very easy to fall down on the basics. Common things are common. We think we know trauma well, but in conveying our answers, we're not very good at this generally. And day-to-day practice, it needs to be known in fine detail. It's something that isn't discussed a lot. Despite being in units where you get a lot of teaching, you may not cover trauma enough, and don't become complacent when it comes to trauma. Basic sciences is the next, let's say, most commonly failed station as well, and people worry so much about the tumour stuff and the obscure pediatric, let's say, congenital deformities and arthrogryposis, they forget about how to discuss the concept and the basic mechanics of a DHS or a nail. So with that in mind, we'll move on to hip fractures. So there are greater than 75,000 of these per year, and the reason for this stat is most hospitals see at least one per on-call shift. So that means that you will on average have one per on-call shift. So it's something that you need to know inside out, and you need to get on top of this and be able to discuss this inside out without any hesitation. It's easy to prepare for these, but it's also therefore easy to fail them, and I need you to be very kind of conscious that you need to start broad on your discussion and on the question that you're being asked, and settle into the question. Start in the ED, and again, you don't want to just jump in to say, this is an extracapsular fracture, I'll do a DHS. You want to highlight that there are points going for the more common stuff. Referral from the ED, and you, as the referring or let's say receiving clinician, need to ensure that all pre-referral care has been initiated. With regards to a focused history, you need to know, did the hip break and then they fell, or did they fall and break the hip? And this would then go into the discussion around malignancies, pre-syncopal events, and also whether or not they're a residential patient in a residential home, they have any other comorbidities, and could you calculate the Nottingham hip score? So the morbidity with these is much worse if you're male, over 85, live in a residential home and have more than 2 comorbidities. Your score for your 30-day mortality is huge. You're easily into double digits, if not into 25% risk territory at that point. If you don't say it, you don't get the marks. Ask for an ECG, ask for a chest x-ray, baseline bloods including full blood count in U&E with a group and save without a CRP. Pharmacy review, or even just your own review of the medications. You have a medical degree, you know how the medications work, you know what you should stop. Stop any insulting agents like NSAIDs and also anticoagulants. Make sure that they're not on them. Check for local guidelines and say that I would refer this patient to the anaesthetist on call for their advice for timing based on this as well. There are some college guidelines with, let's say, the BOA, the RCS and the RCOA as well. Be aware of these and read these and look them up. You as a clinician can commence any care required. So fluid resuscitation, resolving a high CK from a prolonged floor time, you can do this and you have to mention it. If you don't mention it, they can't give you the marks. Local anaesthetic block or an FIB, anaesthetic review, and booking on the next available trauma list. You need to say these things. You need to highlight that I will book them on the next available trauma list, provided they've been appropriately worked up, appropriately consented and fasted, and that the anaesthetists on call are happy to proceed. Fasting status, documentation of neurovascular status and any other issues like vasculopathy, and then discussion with the family regarding the prognosis. Are they a consent form 4? Are they somebody who needs a lot more follow-up afterwards, and you can start discharge planning with regards to social care, support, respite homes, nursing homes. It just shows that you've been on the job, you're not learning it by rote learning from the likes of these lectures or topics, and also it just proves that you are aware that this is a very serious condition. After this, you want to go on and you want to relax a little bit. You can discuss the radiological findings and outline your plan. Again, this is an extracapsular or intracapsular hip fracture. It's not enough if it isn't in the neck of the femur. So don't get stuck into the topic and the nuances. It is a proximal femur fracture and it's extracapsular or it's intracapsular. If it's extracapsular, it can't be a neck of femur. So just remember that you're not calling it enough. Avoid using colloquialisms and avoid using acronyms. I would treat this with a dynamic hip screw or intramedullary nail, a hemiarthroplasty, or a total hip replacement. Then you can justify your answer. So I would treat this with a dynamic hip screw as I see that there is a solid lateral wall. The calcar is not comminuted and the greater trochanter is not comminuted. This is not a reverse oblique type fracture, therefore a DHS or a dynamic hip screw is appropriate. You want to highlight your knowledge, you want to highlight your understanding, and you want to really highlight that you are aware of what you're doing and it's evidence-based. What you then want to go on to is talking about the incidence, or let's say the appropriateness of doing a total hip versus a hemiarthroplasty. The NICE guidelines, they are guidelines, they're not obligatory, they don't have to be followed, they are simply guidelines. But again, knowing that it's not age related, there's no age mentioned on those guidelines. Given the amount that you've spoken about, you still haven't actually put knife to skin at this point. So then you can actually start getting into the nitty gritty that we all want to talk about. And then we're finally in theatre. Position on the list. Does the patient have diabetes and should they be first or should they be on a sliding scale? Set up in theatre. Where are you positioning yourself? Positioning of the patient, equipment needed, and implant choice. Surgical approach. Justify and mention alternatives if relevant. Specific points of concern. For example, if you're using a traction table and you need to put the contralateral hip up in flexion, but they've got OA and you can't move them and they're very stiff, that could be picked up on your initial x-rays and you could then show higher order thinking by talking about it. Also, if the patient's had an amputation on the ipsilateral leg, you can't put them on traction on a trauma table. So what do you do? And there are a number of options that you could consider. Discussion points would be hemiarthroplasty versus total hip arthroplasty in trauma. Is it, let's say, a valid reason to delay the patient's care and, let's say, breach National Hip Fracture Database guidelines based on availability of surgeon? The approach of choice, posterior versus anterolateral versus direct anterior. What are the pros and cons of these? What would you do? What are you competent in? What are you confident in? And what would you choose? If you're doing a total hip, justify your implant choice. Justify your bearing surface. Is it metal on metal? Is it metal on poly? Is it ceramic on poly? Is it ceramic on ceramic? Why? Why not? Cemented versus uncemented versus hybrid. Again, why and why not? What are the pros and cons of each? Are you putting in a constrained liner or not? Or are you putting in an MDM head as well? So you have to be able to talk about the let's say the various topics that are available to you and also the various implants. What I would recommend as well is divvy out the responsibility amongst your colleagues in your study group with regards to the NJR data and implant survival. One person can do hips, one person can do knees, one person can do shoulders, one person can do elbows. These are all things that are easy to prepare, but no one person should have to do it, and you can also spread this out amongst your colleagues in knowing what the most up-to-date data is. So in summary, bear in mind that a hip fracture case and everything that we've just discussed could come up in the adult path viva, the trauma viva, the basic science viva. It could also come up in the long case if it's something that's been done and you're being shown a patient who's had a total hip done. And fair enough, they come in with a problem for something else, but the examiners can bring you back to the initial inciting event, the pre-implant or the pre-fracture x-rays, and also ask you to discuss what you would have done if it's not what has been done. It can also come up in a short case where they'll show you, let's say, a very basic video of a walk with a Trendelenburg gait. It might be something that they show you a patient who's had let's say a long-standing hip replacement for a fracture when they were younger, and now they've got implant, let's say, loosening, or they've got polywear, and again that could be in the short case. So ultimately, hip fractures and basic orthopedic stuff that you see every day can come up in every part of the exam. Common things are common, and predictable questions will give you predictable answers. You can prepare for these, just make sure that you don't lose the opportunity to maximise your points throughout your exam preparation.